Dr. Manjusha Vishwanathan and Dr. Vinu Balakrishnan to kindly take their seats on the dais. It is my privilege to welcome Dr. Shankar VH, Additional Professor and Consultant Genetist, Department of Pediatrics, SAT Hospital, Trivandrum. He will be speaking on reproductive genetics in infertility and IVF. May I invite Dr. Shankar VH? Over to you, sir.
Okay. Good morning. Chairperson, can I start? So, good morning. At the outset, I thank Jayakishan sir, Niranjana and the entire KJK team for giving me the opportunity to talk on in almost last 7-8 advances. But I think my job is easy as well as job is little bit complex. Because previously when I talk, that is the only talk where genetics will be discussed. But today morning I am seeing in every talk there is genetics only. Okay. So I think people are more aware of genetics. So it is a little bit complex. But I am going to discuss only the basic genetics, not advanced thing. Because what I felt, as the previous speaker has expressly shown the implantation failure and all those things. All juniors and others practitioners just understand the last slide. The last slide she specifically told, whatever she told, all those things are on research category. Research category we should not do on patient practice. We can do only on research basis. So practically we may not be able to apply that on the clinical aspect. So what are the things basically you should do for every patient that I am going to do? It will be very simple, but I think all practitioners should know that how to counsel, what to do in those situations. So what is genetics in reproductive medicine? Because advances in genetic testing have become increasingly intervened with the world of IVF and are critical components of reproductive medicine. That's I think told, because last few years the importance of genetics has been increased in ART. Given the complexity of these advances, the inclusion of trained genetics professionals within the field of ART is vital because we have to know all those things. So what are the situations where genetics will come into the play? Already you have heard about the 2 talks, and along with that other talks also some of the genetics has came. So basically it is in the 3 aspects. One is when you come across a case of an infertility or RPL, because I am considering infertility and RPL as a same condition at a different end of the spectrum. One end of the spectrum will be RPL, another end of the spectrum will be infertility, and if you go much advanced, you will get a baby with the structural abnormality or chromosomal abnormality, etc. So basically everything is same. It is a reproductive failure. In one end of the spectrum you are having a RPL infertility or baby with abnormality, recurrent fetal abnormalities, etc. So there you have to identify what is the genetic cause. There you have to do some set of genetic testing. Second thing is identification of genetic diseases transmissible to the offspring, because you are doing an expensive, as far as I am concerned, it's very expensive procedure of IVF. After that you should not get a child with SMA or child with thalassemia or child with a common genetic disorder which is not acceptable to the community, definitely even in public health perspective it is not correct, because it's a very common disease which can be prevented, and we are advising to do in most of the high risk pregnancies. So why this IVF people we are not doing? We have to do a set of tests to increase. Third thing is the optimization of the assisted reproductive technology, where this recurrent implantation failure, high-end test, BCL6, IL6 tubes, so all these rare things will come, which still is in the. So there are 3 groups of tests. First group is very important as a practitioner. So a genetic evaluation of the couple is required or not? Definitely required, because practice committee of the American Society of Reproductive Medicine specifically told before initiating any form of treatment, you have to do a thorough physical examination, laboratory testing, including genetic testing in case of, when you should do, we will come to that, in a case of infertility. So, well, first we will come to male infertility. So what are the main tests you will do in male infertility? You know, you will do a karyotype, because study of chromosome, where you have to look for the abnormality of the chromosome, where you will you can identify the cause, you can manage accordingly. Second thing is Y microdeletion study. These two tests are considered to be the tier 1 of the male infertility. Indication I will come to that, but tier 1 you should think about it. In Western countries and Western literature, CFTR mutations also included. I think we don't, because that is my personal opinion, because in Indian nobody has told CFTR should not be included. But practically even in pediatric patients or other situation, we are not seeing cystic fibrosis, such common condition. So naturally that mutations will be very rare in our groups also. So it is not mandatory to do as a first line of test. Second line of test you can do, and naturally the next step is the exome analysis of next generation sequencing to look for any case of testicular failure. So it's just very easy. One is karyotype plus Y microdeletion. Second group is CFTR plus NGS, because CFTR alone gene sequencing you cannot do in our part. So what we will do is the exome sequencing, where CFTR also will be covered. So only two groups. One is karyotype plus Y microdeletion. Second group is NGS. So this is a case with a couple came for counseling of infertility. They have been married since Tuesday. There are some phenotypic features of delayed puberty, obesity, secondary sexual characters, gynecomastia, hypogonadism, and it is a classical oligospermia. FSH is very high. So I don't think anybody will doubt that we have to do genetic testing karyotype to look for the Klinefelter syndrome, because it's a classical Klinefelter syndrome. It's very, very easy and common, but you should not miss it. It's a very common condition in the tune of around even in population it is 1 in 3,000 to 4,000. So definitely if you take the infertility group, definitely it's much more than that. So every infertility azoospermic male you have to do the karyotype. Second thing is, at the same time you can have a males with the infertility can have a balanced translocation carrier. Here you can see that chromosome number 7, chromosome number 13, chromosome number 3, 4 chromosomes are involved, because it's the two types of translocation. There is 3 to 7 translocation and 13 to 21 translocation in the same patient. So there is a multiple balanced translocation in the patient is there. So you have to do the identify this female partners is normal, and usually the balanced translocation in a male will present as infertility, and balanced translocation in the female will present more commonly as a recurrent spontaneous abortion. Because as you know, males want to do a sperm divide. You have to have a repeated division. So they will get severe azoospermia. Whereas in female, this issue is not there, because ovum is already in the primary oocyte situation. So there is no infertility. Only thing is they can have a baby with abnormality, recurrent abortions and baby abnormality. So if you take the ascertainment, males will have a more 80% their infertility, 20% can have recurrent abortions, whereas female around 70% will have a recurrent abortion. Very rarely they can present with the infertility also. So in infertility and RPL, balanced translocation has to be identified, because already the previous speaker told we have to do the treatment, and you can do a PGT. PGT is not mandatory, because in a situation like ours in government medical college, we will say that you can have a try for normal pregnancy, only you can do the prenatal diagnosis. So somebody has asked that question, RPL even if, so that PGT is important, since as previous PGTA detect only common aneuploidies. PGTA detect only common aneuploidies 21, 18, 13, X and Y. It's a simple fish testing to do common aneuploidy. So a structural abnormality aneuploidy cannot be detected by PGTA. So even that second case, there is 2 babies having 2 structural abnormalities, and PGT has been done. PGTA cannot detect that. PGTA will only show that you don't have no trisomy 21, no trisomy 18, no trisomy 13, no extra X chromosome or Y chromosome. So it is a test for increasing the success rate, it is good. But it is not a definite test for a parent with a balanced translocation. A parent with the balanced translocation, you have to do PGT structural arrangement, or you have to do a prenatal diagnosis again. So in that question, Rama madam has asked that question. In that situation, if it is, somebody has asked that question, if it is a RPL, you have done only PGTA, you have to do amniocentesis, there is no doubt. Because you cannot identify that partial chromosomal trisomy 7 or 13 or anything can be identified by the PGTA. PGTA only detect the aneuploidies, I will come to that later. So karyotyping indication is azoospermia or oligospermia, that is less than 5 to 10 spermatozoa per ml. Second thing is coupled with the recurrent pregnancy loss or previous baby with MR, multiple malformations, structural chromosomal rearrangement, all these patients, you can do that. Then infertility management prior to ART, some people were recommending that because in ART, as you know, that what I mean is, even if there is no azoospermia or something, before doing ART, the couple's karyotype can be done to look for some abnormality. Because I told you, to avoid any mishap or missing things. That's all. So that is not a mandatory thing. That's the third indication I have put. So this is a recent guidelines which they have shown what you should do. If there is a chromosomal abnormality or azoospermia, you can do ICSI plus PGT or a PGT-SR has to be done. Gamete donation can be done, or if a natural gestation prenatal diagnosis can be offered. This is then second is Y microdeletion. So Y microdeletion is second most common cause. 2 to 10% depends on the criteria used. Some Indian literature I have seen around in the 8.4% of infertile. So definitely it will be somewhere around 5 to 10% roughly you can take of infertile men. And more common, definitely. More common means it is indicated in azoospermia. According to the present knowledge, the following recurrent microdeletions of the Y chromosome are clinically relevant and are found to men with oligo and azoospermia. So you have to look for AZFA, AZFB, AZBC, AZC. AZC is the 80%. There are 3 overlapping regions of microdeletions are there. So Y microdeletion testing you should send in case of male with infertility. The test we will do is PCR. It's actually a multiplex PCR. Both these tests we are doing in our lab. Multiplex PCR we can do. There are series of primers are there. I'm not going to nonsense of how to read all those things, but this will help you to say that which is the area where you will get the microdeletion. So what is the recommendation about the Y chromosomal microdeletion guidelines? The indications for molecular diagnosis of Y chromosomal microdeletion is based on sperm concentration, already I told, because in azoospermia it is mandatory, rest of the condition it depends. And AZF testing has prognostic value, because that I don't know because I don't have any experience, because sperm retrieval is different. So they told the micro tissue or instead of conventional tissue, but I am not an experienced, don't ask me any question. Raji is there, you can ask him. Okay. But next thing is more important to me, because third thing, lower embryo quality and blastocyst rate have also been described. So there is a failure, so gamete can be donated or something like that. And most important thing is deletion will be obligatorily transmitted to the male offspring. That most of the people are not known. Because if you have a microdeletion, you have taken the tissa, you have taken the sperm, and you have done ICSI, 100% male offspring will have this by microdeletion. So he will be infertile. But I don't know whether that is important for them, that we have to counsel them. But because it may not be important, because at that time things will be more improved, they can do some other options all. But they will have all their male children will have by microdeletion. Same deletion and they will be infertile. Then there is some literature saying that these type of IVF have more Turner syndrome, ambiguous genitalia, or other chromosomal abnormality. Because since Y is having problem, Y-related issues, why Turner syndromes are occurring? Most of the Turner syndrome, lost chromosome is Y. That I think everybody know. So one X can lost, one Y can lost. But in 80 to 90% of cases, this Y is losing. So because Y is having, that is a Y aneuploidy changes is causing the Turner syndrome. So it is Y microdeletion IVF. So Y microdeletion is parent is having, those type of IVFs have a little bit increase of having these type of issues like mixed gonadal dysgenesis, Turner syndrome, ambiguous genitalia, etc. But it is not proven. So that is I told data is coarse and discordant. So we need further literature on that. Then CFTR gene testing, already I told, you can do a CFTR sequencing or you can do an exome. Definite indication is men diagnosed with a congenital bilateral absence of vas difference or idiopathic obstructive azoospermia. I think this gynecologist knows better than me. I don't know the correct definition of that. And genetic testing is mutation of CFTR gene. You required only the CFTR gene. CFTR gene having more than 200, 250 mutations known. So entire sequencing of the CFTR will be able to identify. And symptoms, and usually this is some specific mutation is causing CBAVD. So these persons will not have other features of cystic fibrosis like recurrent infection or liver problems or mucociliary abnormalities will not be there. They are having an isolated congenital bilateral absence of vas difference. So that is why very difficult to identify them. So if they are having CBAVD, you have to do this. In Indian context, we don't have a CFTR gene sequencing is not really available. So you can do the exome sequencing. And treatment options, ART, microsurgical epidermal sperm aspiration can be tried with ICSI or gamete donation. But one important point is, if that person is having a mutation, the partner has to be tested for cystic fibrosis because it is an autosomal recessive disease. So if partner is also a carrier of cystic fibrosis mutation, the patient may have a autosomal recessive significant form of cystic fibrosis. The baby can have a disease. So that has to be screened, and if both of them are carrier, prenatal diagnosis has to be offered. Okay, clear. And some of the recent developments which I am also recently getting from various parts of Kerala, saying that Y microdeletion, karyotyping and sperm, what is that? DNA fragmentation in sperm. But I don't have any personal experience, we are not doing that. So I have checked what is the recommendation and those things. So sperm DNA fragmentation may adversely impact sperm fertilizing potential, particularly when DNA damages levels are high. So just imagine, in a sperm, if there is a DNA damage, there is a fertility potential will be reduced. So naturally, if the DNA fragmentation is associated with decreased fertility rate, that has been proved. So infertile men frequently have a high SDF, that is also they have proved, but they have told it should be neat semen. The clinical utility of assessing SDF in processed semen is not recommended. That is centrifuge, or because they told automatically the fragmentation will be more. So it should be a fresh, neat semen. And most of the infertile men have an SDF more than 20%, but it is not a diagnostic accuracy is not there. That means above 21% means they are infertile, 19% they are fertile. It is not like that. Generally, when there is a DNA fragmentation is increased, their fertility potential will be reduced. But despite the robust association between SDF and infertility, the limited knowledge and SDF test characteristics and common opinion that SDF is untreatable have prevented the broad application of testing in routine practice. So routine practice is not recommended, but in special situations you can try for that. And there are various steps are there. It is a sperm DNA fragmentation testing in andrologia. Summary of evidence and clinical practice recommendations has been told. There are 3 types of tests. I am not going to the details of the test. One is a tunnel test, which is a flow cytometry, where it is actually a flow cytometry will help to sideline what packs will, so that what areas, it is just like our immunology, we will do flow cytometry. We will be able to know what percentage of sperms having DNA fragmentation. That is the more than 20% we told. If 20% or more than, you will give it, you will get as a values you will get, or you can get a tunnel assay. It is a separate assay where there is a DNA fragmentation is there. The fragmented DNA will be specifically attached to a DUTP transferase, and that will be stained with a green. So there is a green signals here, whatever is green is there, that is tunnel plus, which is the DNA fragmented, whereas red is the tunnel negative, which is DNA non-fragmented. So we will be able to know what percentage or what is the amount of DNA fragmentation. This is called the comet assay, where this is the right side, the dark arrow, where there is only one thing is there, it is a non-fragmented sperm, and rest of the thing where there is a tail is there, where multiple small fragmentation is there, DNA fragmentation is there. So these are all fascinating pictures. That's why I told just I will put for interest you, but I don't have any experience in that. So this is, but generally what they told is, even in a normal individual, there will be some amount of sperm will be DNA fragmented. Because all sperm will not have a normal DNA. Definitely some will be there, but if most of the sperms are showing a DNA fragmentation, that fertility rate will be low. And this is one of the important cartoon which has shown what are the indications, what are the different tests, 15, 25%, everything is there. But the bottom line is, sperm DNA fragmentation analysis is not recommended in the initial evaluation of the infertile couple, with a moderate recommendation with the evidence level grade C. I think this nowadays is evidence-based recommendation. Evidence-based people felt that evidence means any one evidence is evidence. If you have a single case, it is evidence. No, it is not like that. Evidence means it's evidence. You should have a multiple cases, you should analyze that, what is the level of the study, grade of the study, everything you have to do. Finally, you have to say that it is a moderate recommendation or a strong recommendation or a low recommendation, and what is the level of evidence as a, now it is not ABC, it's a high, low and very low. So evidence-based say that it is not the first line test, but it is one of the tests I think little bit I covered, because even I am getting a lot of reference from outside. Gynecologist only, saying that karyotype, Y microdeletion and sperm DNA sperm fragmentation test. We are not doing it, but it is only research purpose, you can do it. Then similarly, sperm aneuploidy testing, it is also you will be able to identify what percentage of sperms are having aneuploidy. This is also very common in the recurrent pregnancy loss and RIF. It is much more easier. Just we will use the same aneuploidy we will use for the PGT or other things, where you can do the sperm testing. In the left side, you can see that only 2 is there, which is only 13 and 21. I told you, this type of fish you can do only for 18, 13, 21, X and Y. This is a specific centromeric probe we are using. That is same PGTA, same Affymetrix or any other things you can use that. So coming to female infertility, similarly a female, if you want to evaluate, basically one karyotype has to be done, because Turner syndrome, they will not come as an infertility. Definitely they will have a primary amenorrhea and other features, but it is also one cause of infertility. And common aneuploid is like a mosaic Turner may have a menarche and some amount of period, then they will go for secondary amenorrhea and they will come as infertility. Very, very rarely. But anyway, you have to look for aneuploidies like Turner syndrome, or it can be a monogenic testing. In monogenic testing, you will have so many genes like FMR1, FOXL2, CYP21, FGFR, NLP. So many genes are there. So I cannot remember. So many genes are there. So you can do a exome sequencing to look for that. But FMR1 is the Fragile X syndrome, which cannot be identified by exome. We have to do a specific test called the TPPCR. Similarly, just like recurrent spontaneous abortion or primary infertility in the male, balanced translocation again can cause here it is 8 and 22, you can see that part of the 8 is extra, 22 is lost. So 8 and 22 is translocation. This type of balanced translocation can present as a primary infertility in a female or a recurrent spontaneous abortion. Both can be present. And it is a couple came for periconceptual counseling in view of infertility. They have been married for 2 years and wife is to have secondary amenorrhea since last 6 months. Her developmental milestones were normal, attend menarche at 12 years of age. Family history of wife's mother with premature ovarian insufficiency. She had menopause at 32 years of age. And ultrasound abdomen, wife showed small uterus, both ovaries okay. Karyotype is normal. This is the ideal case where you have to look for Fragile X. So don't forget Fragile X, because Fragile X is not very common, comparatively common compared to other tests. So if you are a case of a secondary infertility, premature ovarian failure with the infertility, always you have to look for Fragile X. It is a separate test. You cannot do exome. You cannot do any other microarray or anything. It's a TPPCR. TPPCR, triple primed PCR you have to do. Here it is premature mutation carrier is there, TPPCR. So mother is a carrier. Then there are a lot of importance. Even if you do IVF and gamete, a lot of things are there. There's a possibility of transmission, extended family screening, so many things you can do. Now coming to the second part, I will just rush through because it is not very tough. Screening for genetic disorders in couple. Primary objective to inform the couple regarding a possible genetic disorders in their future offspring so that they can take autonomous reproductive decision. What I felt is these are all IVF pregnancy or infertility people. When you are going for IVF, they are high risk, definitely. So we have to screen them for any genetic disorders like Tay-Sachs disease, sickle cell disease, thalassemia, very common in our part. Tay-Sachs is not very common. I just put as a population specific, or is a pan-ethnic conditions like spinal muscular atrophy, cystic fibrosis, Fragile X syndrome, deafness, or it can be a expanded carrier screening where coupled with the family history of suspected genetic disorder, consanguineous families, high-risk pregnancies. But most important thing is pre-test and post-test counseling in this situation is mandatory. Because here so many nonsense are there. You will identify a variant of unknown significance, so many new things, how to counsel, lot of issues are there. So this is one case where you can say G1, G2 is recurrent spontaneous abortion only, but they are planning for IVF because pre-pregnancy loss, they don't want to again take risk, and it is looks like a fetal echinacea, dyskinesia sequence by phenotype. That is all the pregnancy have got almost same type of fetal decreased movement, nuchal translucency, etc., fetal echinacea syndrome. And we have done the genetic testing, we got RAPSN, both parents are carriers of that. So if both the parents are carriers of that gene, there is a 25% chance the babies are affected. So by chance, all 3 babies are affected. So one is they can have a normal conception, again prenatal diagnosis can be done in the next pregnancy, or they can do a IVF with the PGT-M. Or they have to do IVF with the prenatal diagnosis in that pregnancy has to be done, or they can do IVF with one gamete or sperm. very logical. So even though so many too complication is there, I feel this IVF area is too much little bit logical. What are the better option for them? They can do that. So what is the clinical utility of carrier screening? That consideration that determine clinical utility are whether the test, any subsequent intervention leads to an improved health outcome among people with the positive. That's the utility of any test. So here also, if this carrier screening help them to identify their carrier, and if they are carrier, we can do prenatal diagnosis, or those options are available. So definitely. And what risk occur to the result of the testing? There is not risk. Only thing is financial. That financial is also, this is a little bit low now, but that is definitely we have to counsel. It is not totally free. Reproductive options are prenatal diagnosed by CVS, amniotic fluid or fetal testing, IVF, use of donor gamete or embryo, or use of PGD, or adoption has to be done. Carrier screening, but you have to screen that. Just like now ultrasound, people will feel that it is a certified baby with no abnormality. If you do carrier screening, people will feel that I am having a baby with a absolute normalcy. We have to say that it is not possible. We are reducing or improving the outcome, but it is not zero. Because all genes that cause a condition may not known, all genes that cause a condition may not be examined, causative variants may be in a region not included in the test, causative variants may be undetectable by technology, analysis of a gene sequence and the structural variants may be technically difficult, variants may be misclassified with regard to pathogenicity. And most important thing is new mutation, autosomal dominant disorders cannot be identified by any genetic testing in the parents, because that is occurring in the fetus. Coming to PGT, so this type of situation we will use a lot of PGT, but I think PGT one session was there that I don't know, so that 2-3 slides I have put. PGT for aneuploidy will detect only embryos for chromosomal numerical abnormality, especially 21, 18, 13, X and Y. That is generally to increase the success rate. PGT for structural arrangements, PGT-SR, is testing embryos for structural chromosomal arrangements. So if parents have a balanced translocation carrier, you have to do the PGT-SR. And PGT monogenic is previously called the PGD, is the testing for embryo for the single gene defects. Just like we told fetal akinesia syndrome. There we have to look for 2 gene mutations, then we have to do the PGT-M. And PGT-M and PGT-SR is a little bit complicated, whereas PGT-A is comparatively easy. So that is why everybody is equate PGT to PGT-A. But PGT-A, PGT-SR and PGT-M are different, and PGT-M and PGT-SR can be done only by the NGS platform in a high-end setup. So that setup we have to, but nowadays sample can be sent, everybody can do, so it is not a problem. And most important thing is always genetic counseling should be done along with the PGT. Genetic disorder and natural history. Why we are doing PGT is important. All alternative options should be discussed, because PGT is not the single option. What are the nuances of PGT, difficulty of PGT, everything should be discussed. Risk, benefit and limitations of PGT like false positive and false negative. Embryo arrest, extended culture may affect survival. Invasive procedure may affect embryo's ability to implant. Perinatal outcome including neurodevelopment needs a long-term studies, and patient should be counseled that PGT normal embryos do not guarantee a pregnancy or a healthy labor. The only thing is, just like prenatal diagnosis, we can say that diseases may not be there, but rest of the diseases we don't know. So PGT, even though it is an advanced technique, you have to do the detailed genetic counseling. This is technical details and limitations which I'm not telling. This is a technical, various types of tests we will do in PGT, like a phase array, quantitative, single, etc. But mosaic embryos is a already they have been discussed in previous thing, because it is a very, very difficult situation to counsel. It may have both sides. Because we can say that, as madam told previous slide, 80% success rate, that is true, because there is a possibility, correct. But here problem is, we are doing an expensive procedure and expensive counseling. They want 100% result. So at that time, even 20% or 10%, 5% risk may not be acceptable. So risk and benefit always we have to outweigh in that. And if it is a simple test, paracetamol, it will come, reduce, or it will not reduce, okay, we will go next test. Costly illa, side effect illa, risk illa. But here we are giving a test or a intervention which is having a huge thing. So there is a success rate is very high. So mosaic embryos, I don't know how to counsel. It's a very difficult situation. Need for further prenatal diagnostic procedure. These are all I put as red. Madam also told. But it's a very, very difficult situation. Allele dropout in PGTM, it's a major problem. Linkage analysis need multiple samples. Non-invasive prenatal testing, already told, it is a 2025 cells. Then current evidence say that it is a future, it is a good, but now it is not considered to be a good thing because it is not recommended to replace the standard PGT. And mitochondria is always, that's the last slide, mitochondria is a mutation load testing in PGTM and PND, embryo selection for lower the risk. Mitochondrial replacement therapy is an ethical issue, 3 parent families. Autologous germline mitochondrial transfer to enhance embryo development because they told mitochondria is reducing, that is the cause of sperm degranulation or a fragmentation. So you can inject mitochondria into the ovum or sperm so that there is a increased chance of survival. I don't know about the details, these are all literature says. Mitochondrial DNA copy number as a marker of embryo viability. Still lacks sufficient evidence, ethical issues to consider. BCL6, Reggie has already touched upon, this is one thing. So take home message is application of genetics in reproduction medicine and IVS is very high. But we have reached that stage, I don't know. Genetic evaluation of infertile couples should be considered for it. That is definitely we have to do. We can do it. All tests are available, not very expensive. Couple evaluation for carrier screening is a preferred approach to avoid genetic disorder in the baby. Pre-implantation genetic testing is an option in couple with increased risk of genetic disorder. Genetic implantation failure is a genetics cause of implantation recent development needs to have a proper guidelines. Recent advances like NIPGT and role of mitochondria needs further studies. I think after 2-3 years we will be able to discuss that in detail. This is my team genetics from SAT, which we are in some separate department, and we are doing whatever possible to Anita madam and Reggie. We are doing our best to help them in karyotype, microdeletion and other things. Thank you very much for patient listening. Thank you, sir. Sir is here. Thank you, sir, for the opportunity.
Thank you, sir, for that fantastic session. May I request Dr. Vinu to please hand over a memento to Dr. Shankar as a token of our appreciation.